and by applauding the person who you think has spoken best for his view. So you are the judges.
Okay. Not this one now. It's this microphone. Okay. Ladies and gentlemen, dear representatives of Epiphysen, thank you very much for the invitation to come here and duel Professor Andreas Stark on the subject of fixation of hip arthroplasties. I'll try to do my best and convince you that uncemented total hip replacement is best after all. There is ample evidence, I'm sure, that you will be able to show us that uncemented arthroplasty is inferior in some respects, but I think we can agree on the fact that stems in uncemented arthroplasty are not the issue. There are many reports on uncemented stems with excellent long-term survivorships, and by good survivorships or excellent survivorships, I mean at least 90% after a minimum follow-up of 10 years. There's no time to go into the details here, but I think we can agree on one thing, Andre. The inferior cup survival is the main problem of uncemented total hip arthroplasty. So let's have another look at the literature. Are there any good cups around? Well, of course there are. There are lots of reports on uncemented cups and uncemented total hip replacements as a whole that show excellent survival even in the long term. Let's look at these 3 studies that I picked in a little more detail. This work by Gwynne Jones in 2009, 125 Morsha cups followed for 13 years, 97% survival. Ehle 2008, 93 RM cups followed for 20 years, 83% survival. And finally, Shetty in 2005, 134 furlong total hips followed for 13 years, 99% survival. So I think there's no question that total hips can be very good. Now, you might say these are cohort studies, they're useless, no evidence. So let's look at a meta-analysis. Actually, an excellent meta-analysis was published in 2007 in Acta Orthopedica by Morshid and co-authors. And they found, and I cite the authors, no significant overall advantage of one fixation method over the other. And they based this conclusion on this forest plot. You're all familiar with them. If you look at the bottom line, you can see that the combination of all studies fails to lie on one side of the zero line, meaning that none of the fixation methods is superior to the other. Coming from meta-analysis, we climb the next ladder of the evidence steps, and we come to register data. Looking at the Australian Joint Replacement Registry, the latest report from 2009, there's no significant difference between cemented and uncemented total hips after 2 or more years. If you look at the curves and if you look at the p-values, we don't have the time to go into the details, but there is no significant difference there. So finally, let's come to the Swedish register. And I know that you are going to pick this article because this article says that uncemented is generally inferior to cemented arthroplasty. That's a little problem for me. But you forgot something, Andre. When you read that article, take your glasses on, because when you read table number 6, and this has to be magnified because ACTA has very small style, I'll magnify it for you. If you compare the 5 most common uncemented with the 5 most common cemented implants, the risk for revision due to aseptic loosening is actually smaller for uncemented cups when you compare them with the 5 most common cemented cups. And if you look at the 5 most common uncemented stems, then the risk for revision is again lower than for the 5 most common cemented stems. So, to give you the final blow, cemented cups can even be inferior to the uncemented ones. Look at this work from Italy, Bordini 2007, roughly 4,700 total hips. The risk for revision of cemented cups was actually 3 times higher than for uncemented cups, which I think illustrates the fact that you have to do that what you're good at. And if you have an inferior cementing technique, then your cemented cups won't be any better than the uncemented ones. Okay, then finally, revision of cemented total hips isn't really nice. Either you crawl around on the floor and chisel for hours, or it smells terribly.
Well, why cemented total hip is a treatment of choice. I went to the Swedish hip register, you know. I wanted to see what do the Swedish orthopedic surgeons do. Yeah, they use cement. You can see here all these red lines, cemented hips. And I asked myself, are Swedish orthopedic surgeons stupid? No, they aren't. So we went on and, well, here. We went on and I looked up this curve. I saw it in a paper. Cement, the outcome, survival rate of cemented and cemented total hips in Sweden. And guess who wrote this? You recognize him, might a picture. Here, he's playing the guitar among other things. And, well, look what is written. Survival of uncemented total hip is inferior to that of cemented total hip. These have been made to caps. We've heard about that. Yeah, I will show you something about caps. These are uncemented caps. And I gave him the solution too if he wants to revise his uncemented caps. I saw you see it here, and I can tell you again. You see, I have to show how you should do them. And that's not only that. If you use an uncemented cap, you can also get intraoperative fractures during surgery. That isn't nice. And of course, you could say that is what you mean. Mortar cap, that's better. All right. There you have the risk of dislocation. It's like that, and then you have to cement, like this. And then you also have the risk of fracture of the stem. And this is especially clear in elderly people, where the bone quality is not so good. And, you know, we are getting older and older. This 1917, this is 2006. And so see how we're getting older. So, therefore, we shall use cement. Thank you very much.
Okay, let me ask you a few questions. If you go down to the floor here, the exhibition, the industry exhibition, and want to buy a new hip prosthesis, what do you say to those guys? I want a hip prosthesis. They will ask you, well, what kind of hip prosthesis do you want? Well, I want a cemented one. Well, what kind do you want? You can't buy an uncemented or a cemented prosthesis. You buy a specific type. And when you buy a specific type of prosthesis, you first look up the registers, you look in the literature, and you decide this type seems to be good. And can you admit that there are uncemented prostheses? I'm not talking about uncemented as a whole, but certain types of uncemented prostheses that work exactly as good as cemented prostheses. Can you admit that?
Yeah, you can admit that, but you have the danger, and that is the danger, while insertion to get a fracture. And in our population that is going older and older, in our specific country, where we don't have so many people, so it's not a big country, you have to do something safe. And cementation is a safe thing to do for us, as we are very used to that too.
Yes, I absolutely agree when you say that you cannot use uncemented arthroplasty for a population of elderly patients. But on the other hand, I mean, an increasing part of our patients is actually under the age of 60. That's also a number that the Swedish Hip Arthroplasty Register shows. And you showed this nice graph of cemented arthroplasty as being the dominant arthroplasty in the Swedish register. That is true, but you know that there is another graph which shows how uncemented increases all the time by those same clever Swedish orthopedic surgeons.
But very little. It's not so much. It's just increasing very, very little because it increases for a time, and then when it goes bad, then they go back again to the cemented one.
Or it is the reverse. Some cemented prostheses that are loose, because they exist, don't they?
Yeah.
Are revised to non-cemented arthroplasties. Am I not right?
That's right, but that depends on the other hand on the quality of bone. Mm-hmm. I mean, you can't cement something in a hard sclerotic area.
Thank you.
That you can't do. That you'll be aware of.
Okay, but as some of you might know, I had the privilege of working together with André for a couple of years. And do you admit that sometimes on the radiology round, there were x-rays of your patients and there was no cement around the implants? Actually, I remember seeing some mortar cups and...
I make my mistakes. You know, that's what I show you. That is one of my patients. with a dislocation.
So let's get back to those mistakes of yours. What patients received those implants? Were they the 70, 80-year-olds, or were they younger?
Sometimes they were even 70 years, and that was one example that I showed you. And sometimes they were younger, and sometimes I cemented younger patients too.
Okay.
It depended on. You know, you have to, sometimes you want to do something new, and that's the danger. And that's
agree.
we all want to do. We want to put in something new. You want to try something new. That's dangerous.
Yes, and I can absolutely agree with that. Doing new things just because they're new is stupid.
And funny.
Yes.
But
And
sometimes yes.
on the other hand, I mean, things go forward, and sometimes you just don't have the evidence of 30 years behind you. If there were only 30 years evidence that counted, we would still be doing Charnley low friction arthroplasty.
Yeah.
We aren't. Even in Sweden, we aren't. And we're doing other things, even if the evidence isn't 30 years old. I think that you have to give some new principles the evidence of, no, what do you say, the benefit of the doubt. You have to give them some time, but of course the register is an absolutely invaluable tool to sort out those implants that are useless at an early stage, and then we should discontinue their use.
That's quite all right. But still, we are cementing most of the implants, as you saw on that.
That's true, but I also think that the cementing technique in Sweden is very elaborate. We're all using third-generation cementing technique, and if you don't do that meticulously, you will have inferior results. So obviously, the quality of your product, the quality of your prosthesis depends on your technique. That, I think, is one of the reasons why this Italian study showed an inferior outcome of cemented cups. Maybe they didn't have third-generation cementing technique. I don't know. But I think what I take home here is you have to be good at what you're doing. If you're very good at cementing total hips, then there's no wrong in doing them. But if you're doing uncemented hips, do it correctly, get proper training, and avoid the pitfalls. And choose implants that are good, that have a proven track record.
And choose the right patients, because in the elderly populations, we heard that before, 85% will be old and 15% will be working. Then you don't have so much place for uncemented implants.
That is quite right.
Är det sammanfattning då? Shall I go on with the... Okay.
Wait.
We have 2 minutes now. Why we should use cement? I'll just show you. This is because to avoid this. You see uncemented implant, osteolysis, big revision, difficult, it works. And the other thing, you see this year, it's, 70 years in that hospital I'm working in now, and a little crack 2 weeks after surgery, just a little crack. And what happens? It ended up like this, infection, reoperation, not nice. And that is in the population, that is, you see, 2050, it's looking like this. This was 1950. So we're getting older and older. And I think even Isaiah got the message. If you look up the program on page 40, instructional course number 7, Cementing Technique in Hip Arthroplasty by André Stark and Nils Heiler. Thank you very much.
Well, we all make our mistakes, don't we? Let's try to find the right slides here. My conclusion isn't so funny. I think that uncemented total hip arthroplasties can achieve excellent results, provided you choose the right implants, provided you don't break the femur while broaching, because that is a recognized problem. You have to choose the right technique and the right implant, then you can have excellent results, even with uncemented total hip arthroplasty. Cemented total hip arthroplasty also requires an excellent technique, and if we want to continue using cemented total hip arthroplasty on our elderly patients, which I think we should do, then it is absolutely mandatory that even the young residents learn to do proper cementing technique. Otherwise, we'll end up in equal disasters as we do when we when we use inferior uncemented total hip arthroplasties. So I think that there is definitely a place for uncemented total hip replacements in subpopulations of our patients, probably the young ones, the one with bone stock that is good, that have no osteoporosis, and in those patients, I think that even you will continue using uncemented total hip arthroplasties. Thanks.
Very much for a really nice or excellent performance. Now I need the audience to help me to applaud if you think Andrew Stark was the best one. And now, if you think Nils Heiler was the best one, now. I think I know the results. Please, Erika. The winner is Nils Heiler.
Thank you very much. Tack så mycket. Vi ska tillbaka till här, eller hur?
Okay, we have another couple. Please welcome Hans Nosell, Stockholm Söder Hospital, and Ola A. Olsson from Helsingborg Hospital. And they will discuss controlled fracture impaction, the safest way to go in unstable trochanteric fractures. And as you might know, Stockholm Söder Hospital is very fond of intramedular nailing. And in Helsingborg, they use the Medhoff plate with pleasure.
Should we toss a coin?
Yeah, that was
Yeah.
We don't have a coin.
so.
Thank you. Let's shake hands before.
Well, not afterwards.
Good luck.
You need it.
Well, good afternoon, ladies and gentlemen, honored heads of Epiphysen. Thank you for the invitation and the opportunity to fight this battle. Don't start the clock yet. I would like to introduce myself first. My name is Ola Olsson, working at the Department of Orthopedics, Helsingborg Hospital in Skåne, Sweden. I'd also like to disclose that no conflict of interest exists in relation to the subject of this presentation. That was without a slide. Now you can start the clock. Well, the topic of this talk is the unstable trochanteric fracture, and I will discuss 3 different fixation options. The sliding hip screw, intramedullary nails, and the Medhoff sliding plate. These devices all have a dynamic facility aligned along the axis of the femoral neck. The Medhoff sliding plate, in addition, has dynamic capacity along the axis of the femoral shaft, and the sliding of the lag screw is optional. It can be stopped with a locking set screw. These devices represent 3 different principles of fixation, and the dynamic facility, depending on fracture type and depending on reposition and other factors with the surgery, may be more or less effective and more or less appropriate. The difficult intertrochanteric fracture is characterized by being comminuted, multifragmented. It affects bone with poor quality. The patient is old, fragile. You need to achieve a fixation that allows immediate weight bearing. And I'll show some examples of what will go wrong and explain why for Hans.
Thank you.
This is a 4-fragment intertrochanteric fracture. It's properly reduced. Fixation is performed with a sliding hip screw. Is this fracture stable? No. Postoperative follow-up reveals the unstable nature of the fracture. There is no stable contact between the main fracture fragments. Load sharing is poor. There is a weak bony purchase. The proximal fragment is actually hanging on the lag screw. And secondary impaction occurs in a direction that is not supported by the device. And there is a subsequent varus dislocation and lag screw cutout. Intertrochanteric reverse oblique fracture fixed with a sliding hip screw. This is not appropriate since the sliding mechanism of the device is parallel to the fracture line. So sliding causes medialization. There is no impaction, no load sharing. Device remains load bearing, and varus dislocation and lag screw cutout follows. A similar fracture fixed with the Meadow sliding plate. Sliding of the lag screw is locked with this locking set screw. Medialization is prevented. Uniaxial sliding along the shaft, the axis of the shaft, allows fracture impaction and load sharing, and the fracture unites uneventfully. So controlled dynamization is the key to manage this type of fracture. The Meadow sliding plate with biaxial dynamization, the same problem as with the sliding hip screw. The sliding mechanism along the neck causes medialization. Poor impaction, no load sharing. This construct is load bearing, and the device fails. Similar fracture with the intramedullary nail. The lag screw and the nail are actually both in the main fragment, which means that this construct has no dynamic function. It's a rigid fixation, no impaction can occur, no load sharing, and it's a totally load-bearing construct. There is stress concentration at the tip, and a subsequent femoral shaft fracture occurs 12 weeks later. Now, what does the literature have to say? In Cochrane reviews, repeated several times during the last 15 years, the same conclusion applies in comparisons of randomized controlled trials between the sliding hip screw and the intramedullary nail. The sliding hip screw remains the gold standard for fixation of unstable intertrochanteric fractures. And why is that? The most important factor probably that it's the most forgiving alternative, and it's not related to intra and postoperative fractures as opposed to the intramedullary nail. The load sharing capacity is good enough for most fractures, but the rate of fixation failure is 10 to 15% in all fractures classified as unstable, 20% or more for the worst fractures, probably. The Meadow sliding plate, about 1,000 cases in studies during the last 15 years, fixation rate 3%, but in Cochrane reviews, there is still considered to be too limited evidence to draw any firm conclusions in comparisons with sliding hip screw and intramedullary nails. Now, how to cut the last 10 to 20% of fixation failures in the most difficult fractures? You need to understand the biomechanics of the fracture, dependent on fracture configuration, properties of the bone, and understand the mechanics of the device you're using. My last point is actually supporting Hans. You can read yourself. Sorry. Thank you.
Now you can't start the clock for me either, please. While I'll fix this, you think together what kind of evidence do you require to be convinced about the one or the other implant? You have 15 seconds before I start. You can talk to each other if you want to. Okay, unstable intertrochanteric fractures. After this presentation, will you not stand there like the donkey between the two hay taps? You will know that the grass is greener around the intramedullary implants. Okay, and I don't think there's a debate about this. We have the stable fractures. They heal very well. We have the very unstable fractures, the A3 and the subtrochanteric fractures, and there's a heap of evidence that these heal too with an intramedullary nail. So I won't discuss these so very much. Reoperation rate, death, and activity of daily life are but quite good even for these more severe fractures. But we have the problem, the A2 fractures. The force lies medial to the femur. So you have to have a buttress, otherwise it will collapse. And that is what happens when we have these fractures. You lose the medial support, and it all comes down here. Not very good. I don't think so, anyway. So, biomechanics, which implant is best to support this force that will try to destroy what you've accomplished? So, the intermedullary nail is 100% stronger. The plate, it will fail. I promise. And you got the reference there. Also, this is supported by radiological findings, very hard word to pronounce. This is 2 studies, one of them randomized, one with younger patients and one with older, and what will happen? Significantly more often will you see this if you have a plate. So, and there are also randomized control studies, not those that are referred to, or not only in the Cochrane review, because they have quite a lot of old studies when the implant looked different. But what we have here is from Meadle, he's from SÖS, so I'm a bit biased perhaps, but they found that secondary surgery is much more common if you use a plate. Also, infections are more common. You have a bigger wound, more bacteria coming down, and the result is an infection. And not only superficial infections, we had 2 deep infections when we use a plate. Severe complications, they die. 20% of those who had a plate died compared to 10. That's bad, don't you agree? And then we got this one, who's really only in abstract form. It's been presented by Mr. Hip himself and his apprentice, Mr. Parker. And they had this presentation in 2009, somewhere in Germany, I think. And they made a randomized control study with 512 patients, A1 to 3 fractures, so both stable and unstable, okay. Blinded assessor after 1 year, and they found that secondary surgery was much more common if you had a plate. And if you had a nail, you were able to mobilize earlier. So, the evidence, my conclusion is that there is strong and heavy evidence for the intermedullary you know what I mean. Thank you.
Well, time to battle. I would like to start to ask you, after 20 years of intramedullary nails causing intraoperative and postoperative femoral fractures, do you think with new generation of nails, first, second, third, fourth, fifth, seventh, eighth generation nail, do you think that those fractures will be avoided, parallel with knowledge and with better education? Because, well, you should answer first, and and then I would also like to know, facing this battle, we were not equipped with boxing gloves, but with flies. And another accessory that is quite often combined with flies or suspension brackets. And my goal is to have your trousers down. So you may need brackets. Would you like them to be dynamic or rigid?
No, I didn't get the last thing.
Would you like your brackets to be dynamic or rigid?
Yes, I understand. Well, you should remember, the first question, yes, we are now on the 3rd generation of nails. And
I know, I've been counting them.
No.
Yeah.
Well, and that's enough, because now the curve is less, and by that it's biomechanically shown that the stress on the cortexes in the femur is less with these new devices. And that's also confirmed by the new randomized controlled studies, where we don't have the problem with either intraoperative fractures or the postoperative fractures. So that's not a problem anymore, and I still got my trousers on. If I understood you right, the dynamic thing, yes, that's an advantage, okay, with your plates, that you end up with a more stable situation. The nail doesn't allow the same kind of dynamization. On the other hand, it heals anyway, as shown in the randomized controlled studies. Perhaps I could, if I have a patient with very osteoporotic bone that don't mind to have a leg like this when it heals, it's okay with me.
Well, we're discussing the population that needs help for their fractures to unite, and it's a high price to pay to have a non-union and in particularly a broken nail, not to speak about the intra or postoperative shaft fracture, which is a serious complication. Now, your grandmother, unfortunately, has had a fall. She's in the emergency department. Actually the youngest colleague in the clinic is on call.
No.
And you have a phone call, your grandmother is here. She has an intertrochanteric fracture. The lesser trochanter is fractured. The greater trochanter is not fractured, not yet. So, this is a free fragment fracture. The lesser trochanter is broken. Now, do you want, and you say, well, have you operated on this fracture? Yes, I've seen or done at least one of each, the intramedullary nail and the dynamic hip screw. So, which operation would you prefer for your grandmother, performed of the young colleague on call?
Without any doubt, the nail. Because if I let this young colleague, no offense, but if he put the plate there, he will just go straight through the muscle without caring at all about any of the blood vessels. There will be big wound, and he will be standing there moving a lot of soft tissues away from the fracture to prevent it from healing. Instead, if I tell him, you must put a nail there, we'll have a wound this big, up just in the skin up here, and two more wounds. No infection, very little soft tissue damage, so yes. But I will tell him one thing. You better put the sliding nail central in the head. That's the most important thing. Otherwise you can't.
That's true, yes. Now, it's not been proven that you have less bleeding or less morbidity at all. As a matter of fact, that's another question. Going through the muscle insertion on the tip of the greater trochanter, is that really, truly less traumatic than going in the fiber direction of the muscle on the lateral side of your thigh? And then another question. When your grandmother has had her femoral shaft fracture, you need to discuss it with your head of the department. Do you want your head of the department, your boss, to be rigid or dynamic?
Well, I tend to not look at the person. He is very rigid, he is sometimes. But I want him to be dynamic in that question. But when we talk about the fracture, if we're talking if we have a femur fracture, that was your question, which I already told you that that's not a problem, it's not an issue anymore. But then we'll have to have absolute stability, exactly as we have on Södersjukhuset, always.
I think you're right with the fracture, I'll give you that. In dedicated centers, such as Dr. Taglang in Strasbourg, large series, Ms. Parker in Peterborough, they do lots of volumes. But we are living in a reality where those operations are performed by the youngest colleagues, so it needs to be easy enough. So I don't think that the problem with intra and post-operative fractures, I don't think that problem is solved.
I must say one thing. How many of you have tried to use the Medoff plate? Raise your hand. How many find it very easy to use? Okay, I don't. It's very yes. It's very complicated, and you have to be very specific in your how you judge the fracture, because you have these alternatives. You can put the screw there to lock the sliding plate and along the femur, and quite often, and that was a problem with not our study, Meadle's study. They did it wrong, so it's very difficult.
I want to make one more point. This study in 2005, if you had read my thesis, which was published in the year 2000, then you would have known that it was absolutely wrong to have biaxial dynamization with that fracture type. So that study was actually wrong.
Yes.
Where is it starting? Where do we start the slides? Oh, here we are, yes. Okay, so 3 options for fixation, each with strengths and weaknesses. The sliding hip screw is definitely the most forgiving alternative. It does not cause fractures intra or postoperatively as opposed to the intramedullary nail. It is load sharing. Sometimes. It's good for many fractures, actually the vast majority of intertrochanteric fracture, but it's too often not good enough for the worst ones. The intramedullary nail is strong, but that's a mechanical argument, not a biomechanical argument. It has a short lever arm, another mechanical, not biomechanical argument. It's load-bearing, but it's a poor load sharer. It causes intraoperative fracture, stress concentration, late fractures. But I also think that it's better than the sliding hip screw for the worst fractures. The metal sliding plate is the optimal load sharer. But as you said, you need to understand the fracture and use the uniaxial dynamization on the right indications. And wrong dynamization may increase the risk. But it does have the potential to minimize fixation failures and get rid of those last 20%, as opposed to both the sliding hip screw and the intramedullary nail. Thank you.
Okay. Do you want your patient to be able to mobilize early after surgery and keep on mobilizing? If the answer is yes, use the intramedullary nail. If you like to do surgery, you don't, do you? But you want to do it only once, use the intramedullary nail. If time is an issue for you, it might be that you want to get the kids from daycare center or school or whatever. Use the intramedullary nail. You save 10 minutes in each operation. If infection is a concern for you, so maybe, I can't say for sure here, but you should use the intramedullary nail. And I'd say that the evidence are heaping up. There's a lot of evidence now saying that the nail is better. And remember this study. We will see more of it. And remember this hospital. We do a lot of intramedullary nails. Thank you.
Well done. Well done.
So, ladies and gentlemen, please give a big hand to... no, I had to translate this. If you feel like Dr. Olson has been the one who has spoken best for his view, please give him an applause now. And those of you who think that Dr. Nosell has spoken best for his view, please applaud now. So I hope I get it right now. Dr. Nosell is the winner.
Congratulations.
Thank you very much for attending, and see you next year.